excited to be able to talk to you about kids and medication treatment. I think it's one of the things that is a challenge, not only for the children and families, but also for prescribers when we talk about what to do with children who have behavioral health or mental health issues. So today I'll focus on antipsychotics and mood stabilizers in children and adolescents. The first talk that we did was on antidepressants and anti-anxiety medications, and you will be getting information about the third webinar in the series shortly after we finish today. So if along the way you have any questions or you feel like you want to make sure that something gets addressed, go ahead and chat it, and I'll try to make sure that we do pay attention to that. And so we'll be working together to make sure that we don't miss any of the chat questions. So today we're going to cover the following items. We'll talk about FDA status. What does that mean? We'll talk about informed consent for treatment. We'll focus on medications in these two classes or categories. But I also feel it's really important to talk about what some non-medication treatments are. And then I think one of the values of this webinar and you having the ability to chat questions is to really have a discussion about how you can engage with the prescriber. So I hope that we can have kind of an interactive question and answer with that section so that if there are questions you have or the ways that you can get those answered, that we can talk about that. And I can give you my opinion as a child psychiatrist, but I also think that other people on the line might have some ideas that then I can be able to present to everybody. So when we talk about FDA approval, and we did a little bit of this talk before, but when we talk about FDA approval, it's the Food and Drug Administration makes a decision on what medications are FDA approved, in what age range population, and for what diagnosis. And so when they do that, they're really looking at the benefit of the treatment and whether those benefits outweigh the risk. No medication, even an aspirin, is risk-free. There's potentially side effects to every medication, but the FDA really is charged with looking at the data, looking at studies that have been done to see if the benefits outweigh the risk. And so research and testing has to show that for a medication to be FDA approved. And so one of the things that has happened often is that medications will become approved for use in an adult population, but the companies don't do the studies in the child and adolescent population, so those same medications don't have the FDA approval in the child and adolescent population. Studies can be expensive and time-consuming, and I think that's part of the reason why drug companies are not always doing those studies in children and adolescents. And they know that once a medication is FDA approved for, say, depression in an adult population, that we will prescribe what's called off-label and use that often as a psychiatrist, child psychiatrist, or even a primary care provider in a child's population. So when we talk about second, I'm having technical challenges. Okay. So when we talk about off-label medications, those are medications for which they're being used for a diagnosis or an indication that doesn't have FDA approval. And so in the child and adolescent population, you'll see, I'll go through antipsychotics and mood stabilizers. I'll show you which ones have FDA approval and for what diagnoses. But there are many that we're using that don't have that FDA approval, and therefore they're called off-label. That doesn't mean they're bad. That doesn't mean we shouldn't use them. It just means that the studies have not occurred and the medications have not been brought to the FDA for review to consider approval in that age range for that diagnosis. So the informed consent process, I think, is important. And some of the things I'll talk about with every medication class we do. I know some people may be on this webinar that weren't on the last one. But also, I've heard before, it takes 3 times to hear something before it sticks. So I think by the end of this webinar, even if you've done all 3, maybe you'll remember the things that I'm saying that I've said before. But informed consent is the information about treatment that needs to be communicated to the guardian in order for the guardian to say, I agree with that treatment, in order for them to consent to moving forward. And the importance really is that this be an interactive process. You know, in the days of old, the doctor was seen as kind of the patriarch, and so the doctor told you to do and you just said okay. But I think in today's society, there's a lot more information out there. There's a lot more knowledge about things, and more critical that the doctor and the patient and or guardian work together in making decisions about treatment. And so for myself as a clinician, it is not uncommon for me to have someone ask a question about a medication or to try to understand better about what are the benefits or the risks. And as a clinician, it's important for me to accept that and be able to communicate that so that the person on the other end understands why they're taking this medication or why I'm recommending a certain type of treatment or therapy. And so I don't want anyone on this webinar to feel like you cannot ask that question. I know that you're in a precarious situation as a worker within Children's Division because you may not always be at those appointments, and sometimes it's the foster parent who is at those appointments and making those decisions. But you still have the ability, I think, and the authority to be able to ask those questions as a provider and to be able to be engaged in that process. So there are elements to informed consent. There's things that have to or should exist for informed consent to be fully implemented. The first thing is that a discussion needs to occur about why treatment is being proposed. So, okay, you want me to use this medication for my child's bipolar disorder. Why? What is the expected outcome? What should this medication do? And then in addition to that, there has to be a discussion of the risk. What are the risks to taking the medication, and how do they compare to the benefit? Do the risks subsume the amount of benefit that you can get? In other words, is the benefit greater? What are alternatives? So you're coming to me saying, you know, you really should use Depakote for bipolar disorder, but are there any other alternatives? What other medication options are there? What other non-medication options are there? And be able to talk about that so you can kind of understand the process of selection. And usually, as physicians, we're not just picking a medication out of the air. There's a reason or a rationale behind why we choose one thing versus another. And when you talk about risks and benefits of that proposed treatment, you need to also talk about risks and benefits of the alternative, the other medication. And what would happen if I just didn't take medication? What is the risk? What is the benefit of not having treatment? Also, the FDA status has to be discussed, and then the possible side effects. Now, I'll be the first to say, if you take a medication and you look in our PDR, physician desk list, right? It's huge. It's right behind us over there. It's going to list 1 million potential side effects because when the studies happen, they have to list anything that a patient commented about during that study, headache or dry mouth or whatever, and then they give you the higher percentages of those, right? When a doctor's talking to you about a medication proposal, they're not going to go over every single one of those. They should really talk about what are the most common side effects and what are the severe side effects. What are the things that you really have to be aware of because they could be life-threatening. And so today when I talk about some of those medications, that's the stance I'll take is really what are some common side effects and then what are some severe, really serious side effects that might be rare, but you need to be aware of them in case they happen. So let's start with antipsychotic medications. And so you have first-generation antipsychotic medications, and you have second-generation antipsychotic medications. And I've listed just the names of all of them. I've listed the names in the generic format. So chlorpromazine is the name of the generic medication. And thorazine is another name for it. So it gets confusing if you don't always know, and I'm not saying you need to know, but when you see the different names, you'll see a generic name, sometimes a trade name. Things that have not gone generic yet may only have that trade name, but that's kind of the reason that you'll see, you may think of Abilify, and that is aripiprazole. So the generic name is aripiprazole, the trade name is Abilify. And so I think the only reason I mention that is because of the confusion that sometimes exists when people are looking at the different names. And it's okay to ask that question so you can be clearer about the medications that people are taking. So the first generation, or the older antipsychotics, this lists their approved indications. And when I say approved, I mean the FDA has looked at studies and they've said for this diagnosis and this age range, these medications are approved. And so if you look, we have, 6 of the older medications that are approved. And the reality of the diagnoses they're approved for is really only schizophrenia, Tourette's disorder, or severe behavioral problems. And that's a little nebulous, but that's the way it's listed for Haldol and for Thorazine or chlorpromazine. And if you'll see the age ranges that often we don't see approval in young kids. Haloperidol or Haldol does have an approval in younger kids with Tourette's, so 3 years of age. And it just lists children. It doesn't really list an age for severe behavioral problems. The second generation antipsychotics are the newer antipsychotics. Those are the ones that you'll probably see more often. Those are the ones that are used more frequently. And I'll talk a little bit about side effects and the rationale for probably switching from use of first generation to second generation antipsychotics. So there's a listing of the ones that are FDA approved. Now if you go back and remember, that list of all the first generation antipsychotics was long, and the second generation antipsychotics was even longer. So let me go back and show you. So there's a lot of medications that exist, but when you break it down to what is FDA approved in children, that list becomes smaller. Here's the first generation, here's the second generation. And so the second generation antipsychotics are really approved for 3 diagnoses. Schizophrenia. There's a table at the bottom that tells you what the acronyms are. BPD is bipolar personality disorder. Bipolar disorder. And then autism spectrum disorder is ASD. So schizophrenia, bipolar disorder, and autism. Those are really the 3 indications to use second generation antipsychotics. And if you look at the ages, the only thing that is approved in younger kids is really the autism spectrum disorders, which have the approval of 2 antipsychotics. Everything else is clustered closer to the teenage years, 13 to 17. We have some 10 to 17. Just in case there's confusion, you have schizophrenia, you have bipolar disorder, but there's various types. There's manic bipolar disorder, there's mixed bipolar disorder, and there's the maintenance bipolar disorder. And so the treatment is based on the type of bipolar disorder that is there. That's what the studies were done for, and that's what the FDA approved those for. So the first generation antipsychotics are called the typical antipsychotics. They're the older antipsychotics. And the second generation are called the atypical antipsychotics. They're the newer ones. So when you look at the older ones like haloperidol and chlorpromazine and fluoxetine, some of those have an injectable form that will last for a month. Haloperidol does. Fluoxetine, I think, is a 2-week formulation. They, whether they're oral, like pills, or injectable, they have a higher risk of EPS. And I'll talk a little bit about what EPS is. So that's extrapyramidal symptoms, but that's important to be aware of. That's one of the reasons why the first generation antipsychotics are not used as much anymore, because of that risk of EPS. It's not as if the second generation antipsychotics don't have their own baggage. So they come with the potential of a higher risk of metabolic syndrome. They're used more commonly, but we do have to be cautious about the potential of metabolic syndrome. So when you look, when you look at safety related to the second generation antipsychotics, when you look at safety and you look at adverse effects, children tend to be more susceptible to some of the side effects that we have with the second generation antipsychotics. So they're more susceptible to being sedated, having what we call withdrawal dyskinesia. So what is that? Withdrawal dyskinesias occur when you stop an antipsychotic. You have movements, abnormal movements or dyskinesia that happen as a result of stopping the medication. They're more inclined to have endocrine abnormalities, weight gain, and other metabolic side effects. We don't have a lot of studies that look at safety and tolerability in this age range, and even fewer studies that really look at long-term. So what's it like 5 years on an atypical antipsychotic or 10 years later? So we're using those medications, using them sometimes on label, sometimes off label, and not having long-term data to really look at how it impacts or affects the brains or development of children. It is, though, sometimes unnecessary that we do use those medications. I would advocate that we need to be, when you think about antipsychotics, and I'll talk about some of the metabolic effects, I would advocate that there would be cautious, judicious use of those medications. There's a place for them, and I think my opinion is that sometimes they can be overused. So these are the second generation antipsychotics, the newer ones that are used more frequently. And the common side effects are listed there on the one column: sedation or sleepiness, upset stomach, nausea, constipation. The prolactin can be elevated. So I list the two medications that do that more frequently. It doesn't mean that the others can't do it. They're just not as frequent. And so prolactin is a hormone that is elevated in women who are pregnant. And that's a normal part of pregnancy. If you have an elevated prolactin in someone who's not pregnant, you might see gynecomastia as well, which is development of breast tissue, even in a boy. You could see galactorrhea, which is leakage of fluid from the breast. And so those can be pretty concerning to patients who are having that. And so I think it's important to talk about that prolactin elevation. Prolactin levels can rise and fall with age and development and depending on sex, but we definitely see an elevation above and beyond normal, higher in the antipsychotics, and even more of a risk with these two. You may see some heart issues, cardiovascular issues. So the QT interval may get longer than it should be. That's more common with Seroquel, but that's a possibility. Although I said that the first generation antipsychotics have the risk of EPS, and that's very true, they do, they have a higher risk than second generation antipsychotics. But the second generation antipsychotics can also cause EPS. And these are kind of the four components of EPS, which I'll go through in a little more detail. The thing that is more likely is the metabolic effects, the weight gain, increased cholesterol, increased triglycerides, glucose intolerance, and even diabetes. So if you look at the different antipsychotics that are listed here, and kind of the risk of those metabolic side effects that are listed, the weight gain, the lipid metabolism issues, the diabetes or high glucose, it is less likely to happen with those antipsychotics that I'm listing on the top, like Abilify and or aripiprazole or Latuda, which is lorazepam. More likely to occur with the ones at the bottom, so olanzapine, which is Zyprexa, quetiapine, which is Seroquel, paliperidone, which is Invega, risperidone, which is Risperdal, and acenapine, which is Staffer. So it kind of shows you with increasing possibility of which ones are more likely to cause those metabolic side effects. So those three at the top are kind of going to be your one that you might think of as, if you're worried about that more, you have an issue with a Risperdal or olanzapine, you might consider those ones at the top versus those at the bottom. And olanzapine being kind of the worst of the list. So I did say I would talk about EPS. So EPS is extrapyramidal symptoms. They happen with all antipsychotics, but are more likely with the older antipsychotics. The reason why we use the newer ones is the lower risk. The things that can happen are akathisia, and akathisia is like an internal restlessness, so this feeling inside your body that you need to move or pace. And you may see someone on haloperidol or chlorpromazine who's walking around all the time or just can't seem to be calm in their own body. Then there's tardive dyskinesia, and tardive dyskinesia is involuntary muscle movements, usually in the face or the distal extremity. So you can have tongue smacking, lip rolling. These are not things that people are doing voluntarily. They can't stop. You ask them to stop and they can't stop. And so that definitely can be a challenge. Tardive dyskinesia, once it starts, is irreversible at times. So if you have a child that you put on an antipsychotic that's 10 years of age and they get tardive dyskinesia, it may not ever go away. There have been some people who've tried vitamin E and some things like that to help with tardive dyskinesia, but it's definitely not universal that it does make it go away. And if you see severe cases of tardive dyskinesia, they can't even really communicate because their mouth is moving so much all the time. It is, again, one of the reasons we went from the older antipsychotics to the newer ones because you see it less, but it's still possible. Then there's pseudo-Parkinsonism. So if you know what Parkinsonism is, you see or think of maybe an older person who has this shuffling gait and they don't have much expression to their face. They have what's called a masked facies, and they're really rigid in their body, and their movements are kind of jerky. So that is what can happen with some of the antipsychotics. Salaria is like S-I-A-L-O-R-R-H-E-A, is like drooling, right? And so you can get drooling or stoop posture. All the things you see with Parkinson's, you can get as a drug-induced Parkinsonism from antipsychotics. And then there's dystonia, which is that muscle spasm that can happen where you just kind of lock up. Maybe it's your neck or your back. There's an oculogyrate crisis that I've seen before where people's eyes will kind of just go up and they can't move them. They're stuck. Dystonia can be treated with like Benadryl or something like Cogitin, but it's, I've had a little kid who got that before, and it was very traumatizing for him. And every time I saw him later, he's like, "Don't give me that Haldol again," because they just equate every time I get that medicine, I'm going to have this dystonic reaction. And the challenge is that in a young male population, including children that are male, there's a higher risk of dystonia. So there is a question that I want to answer, and it goes back to this last slide that I talked about, I think. It goes back to, not the last slide, but the slide where I talked a little bit about prolactin elevation. So there's a question. I've had several people tell me that risperidol causes males to grow breasts. Is this true? So when I talked about gynecomastia, that's a huge word. Gynecomastia is the enlargement of breast tissue. So yes, you can see that in a male and a female if the prolactin level is high enough. And so yes, it is a potential risk or side effect. And I don't know if you watch TV much, but you see on TV sometimes law firms that say, were you on risperidol and did you have this, that, and the other? And growing breast tissue is one of them. So let's talk a little bit about metabolic syndrome. If you remember, I said this happens more frequently in the newer antipsychotics, the ones that we're using more regularly. That's gaining a lot of weight. There have been some kids who gained 30 and 40 pounds in like less than 3 or 4 months from antipsychotics. There's abnormal glucose and lipid metabolism, which leads to high glucose, high lipids, a risk of diabetes, and sometimes those don't go down. So once you have a child who you've caused an elevation in glucose, you might think about switching to one of those top-tier medications that I talked about, but there's not a 100% guarantee that that's still going to become normal. And so the highest risk for metabolic syndrome really comes from olanzapine and clozapine. That's the highest risk. Now, I want to make sure we talk about this because it's a risk of antipsychotics. It is rare, but it is a life-threatening problem if it happens. I don't know if you've heard before of neuroleptic malignant syndrome, NMS. When it does happen, people usually end up in the hospital. The treatment is really only supportive care. There are some things that can be given, I think, that can be used, but what happens with someone with neuroleptic malignant syndrome is it's often caused by an antipsychotic, and they have rigid muscle, so muscle rigidity, fever, and they can have a high fever. And when I say autonomic instability, that means that their vital signs are going back and forth. So they've got high blood pressure, and then it's low. Their pulse is up and then down. So their autonomic nervous system is not functioning appropriately, and you're seeing the vital signs be all over the place as a result of it. And cognitively, the way they engage with you, it may seem like they're delirious. You know, they don't know where they're at potentially. They can't say in the day. They just don't seem to be with it at all. And on labs, we'll get labs and see that the creatine phosphokinase is elevated. And that lab result in the context of use of antipsychotics with these other symptoms, especially the fever and the autonomic up and down of blood pressure and pulse, and the muscle rigidity make you concerned about neuroleptic malignant syndrome. It can result in death. There are cases where it's caught. People are placed in the hospital, they're treated symptomatically, and then it's able to be resolved. But it's one that if any child is taking an antipsychotic, all of the people in that child's life need to be aware of the possibility of this, so that if they start to see the constellation of symptoms, and it's not just one, kids get fever all the time. They may have strep throat or whatever, just a URI, upper respiratory infection. But when they have the constellation of all of the symptoms and are really sick, then they need to see somebody. So this is recommendation by the ADA, the American Diabetes Association, about monitoring patients who are taking second-generation antipsychotics. The reason for this monitoring is to ensure that they don't end up having metabolic syndrome, that if they're starting to get those symptoms, that they're identified early and then addressed. So it shows you like at baseline, 4 weeks, 8 weeks, 12 weeks, quarterly, annually, and every year, what should be done. The providers should be aware of this, and I'll say that HealthNet has done a really good job of trying to educate the providers on making sure that they're checking their fasting lipids and glucose at least once a year, once they get past that initiation mark. But, you know, before you ever start a medicine that's a second-generation antipsychotic, you should really get that family history and get that personal history and make sure that there's not pre-existing diabetes or high risk of it. And so that plus the BMI, the waist circumference, blood pressure, blood sugar, or fasting glucose and fasting lipids need to be taken at baseline before the medicine is ever started. And then you'll see that that weight is checked about at 4 weeks, at 8 weeks, at 12 weeks, and quarterly. So the weight is checked pretty regularly, and that's important, the weight/BMI, because then you pick up on those kids that are gaining 30 or 40 pounds in a short amount of time. The blood pressure should be checked with the labs again at the 3-month mark, and then annually you need to be checking these things with the exception of, I'm sorry, that last column I think is every 5 years, with the exception of the fasting lipid, which is asked to be checked every 5 years after that, if it's normal. So if you check a fasting lipid and you have abnormal cholesterol or you have abnormal triglycerides, then you probably need to be checking more frequently and considering whether or not you want to change that medication to something different. So I think I mentioned before, but I just want to make sure you're aware of the American Academy of Child and Adolescent Psychiatry. They are the kind of body that we as child psychiatrists look to for practice standards. Many of the medications that we have are really off-label, as I said before. And so the American Academy of Child and Adolescent Psychiatry has practice parameters for various things. And they have one for the use of atypical antipsychotics in children and adolescents. They also have them for depression, bipolar, PTSD. If you go on the website and you're not a member, you can still access these practice parameters. And so I've included in the presentation a link, and I'm pretty sure after this you'll get a copy or it's available on the webinar, where you can use that link to be able to pull up practice parameters and see all that is out there. ACAP looked at findings. They looked at different antipsychotics, and the ones that are in yellow have FDA approval. So sorry, I've gone way too far. So the plus marks that are yellow are where there's FDA approval. Black is where there's not FDA approval. And so you'll see, I'm sorry, I'm trying to move the chat box and talk to you at the same time. So you'll see that schizophrenia, it shows the more plus marks you have, the greater the evidence for success in that treatment. And if they're yellow, they're FDA approved. And if they're black, it's going to be off-label, not FDA approved, right? And so you'll see, like for autism, it is FDA approved. 2 medications are FDA approved for the irritability associated with autism, and that's risperidone and Abilify, or risperidone and aripiprazole. So that's why it's yellow, and the evidence for that is strong. That's why there's 4 plus marks, right? Long-term safety, we really don't have. We have some studies that look at long-term safety in risperidone and quetiapine, which is Seroquel, but the evidence about long-term safety is minimal, which is why there's just 1 plus. And we don't have any studies that really look at long-term safety of the other medications. So there are other antipsychotics that are out there, but AACAP looked at the studies that are out there, the medications that have been studied, and kind of gives you a summary of the evidence. So there's a question in chat. Is the PowerPoint available for us to print?
It will be posted to the calendar invite with this invitation webinar.
All right, so it will be posted to the calendar invite for this webinar, and that way you can print it. Whenever I change from chat to presentation, I always have to do something I don't do. So let's talk about conclusions from the AACAP about antipsychotics. So if you look at, the practice parameters, you can read everything they have to say about it. If you look at my table, it gives you a little bit of a summary. And the conclusions really is that there's not a lot of rigorous studies that look at use of second-generation antipsychotics in children and adolescents. The evidence that we do have is really the most strong for 2 diagnoses, schizophrenia and bipolar disorder. And the evidence that is out there for using antipsychotics for disruptive behavior disorders, aggression, which I'll talk about a little bit later, is much less robust. We don't have a lot of evidence except in 1 diagnosis, which is autism. So if you're an autistic child who's aggressive and irritable, we have an FDA-approved medication that the evidence shows that it works. We don't have long-term data about safety, but we have efficacy data. We don't have it for aggression, just aggression. We have it really for aggression associated with autism. So this is a handout that the American Psychiatric Association gives, and it's 5 things physicians and patients should question, right? And so you'll have that. I'm not going to go through all of it, but when an antipsychotic is just being given without that appropriate initial evaluation and without ongoing monitoring, and I talked about, you have to get a weight every time and monthly and a BMI, and you need to get your fasting lipid and glucose at 3 months, and then again your glucose every year. You need to be questioning if that's not happening. They also say don't routinely prescribe 2 or more antipsychotics at the same time. We don't have evidence, and there are prescribers that do it, but we don't have evidence to say that if risperidol's not working, just go ahead and add Seroquel, it's going to make it better. Don't use antipsychotics as the first choice, and this doesn't happen in kids as much. So the APA, the American Psychiatric Association, is the adult counterpart to the ACAP, right? And they're saying don't really use antipsychotics as the first choice with dementia because there's some side effects that are higher risk in that population. That's why it says that. And then in adults and kids, sometimes antipsychotics are used for insomnia. So this is my opinion. You can't sleep. I'm going to give you a medicine that may make you diabetic. What is more risky? Is it the not sleeping, or is it diabetes that as a child you will maybe never get rid of? And so for prescribers who are saying, take the Seroquel, it'll help you sleep, there's a high risk in taking Seroquel only for sleep. True, there are some people that have bipolar disorder and not sleep. Okay, so you're using now Seroquel for an FDA-approved indication, and you're using it for more than one thing, sleep and the issues with the mood. And then the fifth one is don't routinely prescribe an antipsychotic medication to treat behavioral and emotional problems in childhood mental health disorders in the absence of approved or supported evidence. So don't just do it just because, have some evidence behind it. So that fifth one I think is really important. This is the APA. You can look at the ACAP practice guidelines and you'll see similar things as to what APA is saying as well. So I want to talk about what has become controversial a little bit related to the use of antipsychotics. So one is using antipsychotics to treat anger and aggression, and I've alluded to that some. It's a common practice at times. It is off-label, unless it's an autism patient. And when you think about aggression, aggression is a symptom, not a diagnosis. Aggression as a symptom can be a part of different diagnoses. And if you might treat the diagnosis, you might see the aggression go away. In other words, if you have a kid who's been abused physically, and he acts out or she acts out physically with other people, is physically abusive, aggressive, hurting people in school, is that aggression a symptom of trauma? Is it potentially a symptom of PTSD? And if you treat PTSD appropriately or trauma appropriately, will the aggression go away? And I think what's happened, or what I see happen, is the easy answer is a child comes into the office, they're hitting at school, the school saying they're going to kick them out, and so here, take Risperdal. And there's not that concerted effort to really get a sense of where is it coming from. Because if you know where it's coming from, you might be able to address it even without medicine. Maybe there's another way to address it, but in our society, a pill is often the quick fix. It's the way to go because you might get some sort of benefit right away, which usually doesn't happen, in my opinion. There's not a immediate fix for some of the challenges our children are having. So that's one controversy, is using antipsychotics for anger or aggression. And another controversy is then using more than one antipsychotic. So you saw that the APA is saying there's not evidence to say use two, right? But it happens, and it happens more regularly probably than I feel it should. So let's talk about aggression. Aggression is really defined as hostile, violent behavior, attacking others. It's not an uncommon thing to see during childhood and adolescence in general. I don't know if anybody else on the line has kids, but I have a 16-year-old and a 12-year-old, and I don't know how many times I say, don't hit your sister, right? Does that mean I go home and give them Risperdal? No. It's a part of their development and growing up and learning how to navigate, how to engage with other people. I'm not trivializing it. I know some children have much more aggression than that, but some amount of aggression is common. You see it as kids grow up. And it might be an associated feature of other disorders, like I talked about trauma. Persistent aggression is associated with negative outcomes in later life. So you have someone who is continuously having issues with aggression, and they're socially isolated. Maybe it goes on for criminal behavior. And later in life, it can definitely impair things if it's persistent and someone doesn't work to navigate and modulate it. Sometimes it's just, with some of those normal developmental tasks, it's just helping a child to see other ways. Think about a 2-year-old who doesn't have language, and another 2-year-old takes away their toy. What is the first thing they do? They hit them, right? They have to learn how to engage with other people, and I think that has to be a part of the discussion and what we do with kids who are having aggression. So it falls typically into kind of the categorize categorize it as externalizing behavior, or maybe impulsive, or maybe they're hyperactive and then they're acting out, or delinquent. And Connor kind of looked at aggression and gave it different categories. Is it reactive versus a proactive aggression? Is it offensive or defensive? So he's kind of looked at how to categorize it. And I'm not saying that everybody has to do that, but it's a way to kind of think about what is the aggression, what causes it, and you would deal with someone who is more reactively aggressive in a different way than someone who just reaches out and starts things. And so, given the big impact that aggression has on outcomes, we do have to look at it. We can't ignore it. We have to properly figure out, is it falling within a diagnosis that we need to address, and really intervene. So I've listed here, possible diagnoses where you can see aggression, right? It doesn't mean that aggression is the main theme of that diagnosis, but it's a possibility of occurring within those diagnoses. And so when you're looking at aggression, really it involves really looking at the interview, and there are some assessment tools, and I'm not a psychologist, but they might do an evaluation that will help you with assessing, and then determining what the diagnosis is, if there is one, and then what the next treatment could be, right? So treatment is often focused or diagnosis-based. But in general, cognitive behavioral therapy has some evidence to show that it is useful for addressing aggression and aggression symptoms. Another thing, problem-solving skills training, has been studied and found to be effective in helping with aggression. So that's my antipsychotics and aggression. I want to talk about mood stabilizers, but there is a little bit of overlap. So antipsychotics are used, as you saw, there's some FDA approval for bipolar disorder, which is a mood disorder. So there's some overlap between the use of mood stabilizers and the use of antipsychotics for mood-related issues. Here you have mood stabilizers that are FDA approved and what the FDA approval is for. And you'll notice that many of them, and some of them started with a seizure disorder FDA approval and then went on to get bipolar disorder approval, either manic or maintenance. So maintenance is when maybe they've gone through a manic episode and they're not currently depressed, but you need to continue treatment to prevent a future manic episode or depressed episode. And so the FDA approval really with the mood stabilizers is lithium. If you remember, there's some antipsychotics that have that approval too. So here I've listed kind of the common, I've listed some of the common side effects and then some of the things that you really need to be cautious about. So mood stabilizers can commonly cause sleepiness or sedation, upset stomach, dizziness, and nausea and weight gain. There is a risk of birth defects, and you have to be cautious for sure with lithium can cause some birth defects. Also neurotube defects with Depakote. But there's a risk of birth defects should someone get pregnant when they're taking mood stabilizers. So part of the conversation, and this may happen even with our teenage girls, is that if you're taking these medications, you really need to be on some sort of birth control because of the risk to an unborn baby if you're on them and get pregnant. With lithium, tremor or handshakes is pretty common. Lithium has a narrow therapeutic index, which means that there's a narrow range with which you see efficacy or effectiveness, and if you go past that range and the level gets too high, it can be toxic. And lithium actually can cause toxicity and death. It can cause long-term nerve damage. So lithium is a medication you really have to be cautious of. I'm going to talk about labs and what you need to check when people are on lithium too. But it starts with that kind of slight tremor that gets worse and worse as the level of lithium gets higher in your body to a coarse tremor. There may be some increased thirst and urination as well as far as some common side effects. That general tremor might be more common, but as the worsening of it occurs, you really have to be cautious about toxicity. And then with Depakote or valproate or divalproex, you may get increased liver function tests or liver enzymes may elevate, and this is really concerning in young kids, less than 10. Also, there's not listed here, but polycystic ovarian disease can happen with Depakote, and so there's caution in use with teenagers, and then also decreased platelets. Carbamazepine, which is Tegretol, you get that elevated liver function test again, maybe low sodium or hyponatremia. And the thing that is life-threatening, I've kind of bolded there, which is Stevens-Johnson syndrome. And not only is a risk with carbamazepine, it can happen with other medications too, but Stevens-Johnson syndrome is a rash, but it can be a fatal rash. And so it's a rash that starts and then encompasses the body, and it ends up with people really seriously sick. It's very rare. It is not common, but it's something that people need to be aware of if they've got a new start of carbamazepine and a child all of a sudden has a new onset rash. Agranulocytosis can happen too. That's a reduction in kind of the cell count. So that's part of the reason. A lot of these side effects are seen by labs, and so I'm going to talk to you about the different blood work and labs you need to be monitoring. Sorry, okay. So you have lithium, you have valproate, which is also called Depakote, which is also called divalproex, depakine. There's various formulations of lithium. There's lithium carbonate. There's different options. There's Escalus, which is like a sustained-release lithium. But it shows here, and you'll have this presentation so you can kind of print it off and keep it with you, like how often you should be checking it for the level. So all of these medications have a therapeutic level. For lithium, it's like 0.8. For valproate, it's 80. And for carbamazepine, it's 8. It's the rule of the 8. That's the way I think about it. Now, there's a range, of course. But if you're close to that 0.8 on lithium, 80 on Depakote, or 8 on Tegretol, then you're going to be good. It's like 8 to 10 for carbamazepine. It's like 60 to 100 for valproate. So there's a range, but that rule of 8 is kind of right in the middle. And so you should be checking, if you start somebody on lithium, every week until you've got a stable level. And then every 3 to 6 months. For valproate, it's 5 to 7 days after starting or having any increase. And the same for carbamazepine, 5 to 7 days. And then every 6 to 12 months, just checking a level. Anytime that you have a change in dose, you recheck a level. Anytime you have some potential side effects that you're concerned about, you should be checking a level. And then a CBC is a blood count. LFT are those liver function tests that I talked about earlier. You have to get a pregnancy test in everybody before you start this medication because of the risk to the newborn baby from birth defects. Electrolytes, that's like your sodium, your potassium, those kind of things, and how often you check that. Renal function is your kidneys and how well your kidneys are functioning. And then TSH is thyroid. So it kind of is a table that shows you at what frequency and what lab should be checked for each medication. So the American Academy of Child and Adolescent Psychiatry is where I go often for kind of the guideline on what to do. Some of their practice trainers are older and they're in the process of updating them, but they do give us guidelines for the treatment of bipolar disorder with psychosis and without. So psychosis is really hearing voices or seeing things that no one else hears or sees. And so you've got the table at the bottom to show you what Li means. It's lithium, right? VPA is valproate or Depakote. CBZ is carbamazepine. So it shows you the different medications. And if a patient does not have psychosis, then one mood stabilizer or a second-generation antipsychotic is okay. And so it lists the different ones in the first line that you can use. If you get a partial response from one, then they recommend you augment or add a second. Okay, so this is where we do see with bipolar disorder sometimes two different medications, and it shows you if the first medicine is lithium, these are some potential augments. If it's valproic acid, then these are the three options. Not all three, one of them. If it's carbamazepine, then here are the other options. And then if you don't get a response, then you might switch to another single agent. So the rule, or without psychosis, is try one medicine. If there is no response, try a different medicine. If there's a partial response, add a medicine. So then you go to our second column, which is if there is psychosis present. And if there is psychosis present, then there's some evidence to say, try a mood stabilizer plus a second-generation antipsychotic. If there's no response, then try a different combination. And it shows you kind of any of those mood stabilizers, one of those, with a second-generation antipsychotic. And if you get a little bit of a response, it gives you some options for what to do next. Bipolar disorder is controversial in children and adolescents. There's some studies out of WashU with Barbara Geller that give us some data about bipolar disorder in kids. But it is one of the illnesses that if there's an accurate diagnosis, we have some data from ACAP that kind of guide us in how to treat and what to do with treatment. So there are some other mood stabilizers. They have minimal evidence in children and adolescents, but I list them because you may see them. Your children may be prescribed them, and they don't have FDA approval. They're often not used alone. They're often used in combination with other mood stabilizers. And that's gabapentin, which is Neurontin, but it's also topiramate, which is Topiramate. So when you are working with your doctor or prescriber, and they're trying to figure out what they're going to use to treat whatever the illness is that they've identified through assessment, really there's lots of things that they look at. They look at what's the past history. So what have you taken before and what's your response been like? What's your family history? So if I have a child who has bipolar disorder with a mother who had bipolar disorder, and I know this mother responded very well to valproate, then I might start there. Each medication, when you look at them, they have a different profile as far as what receptors in the body they engage with, what neurotransmitters they engage with, and so that may be one of the things that makes a decision in what you use, but often that family history and that history in the past is commonly part of what the decision-making is. Also, if they're on other medications, we'll look at what are the potential interactions from adding this medicine versus medicine B. Dosage is an issue. Sometimes you know that a child is not going to take medicine 3 times a day, and if you know you have to dose this medicine 3 times a day, you may go with something that's more of a once a day because of adherence, medical history, cost. If you've got a child who's tried things and been refractory, you may go right to the combination treatment for bipolar disorder, pregnancy and lactation, patient preference, and side effects. So there's a lot of things that go into that decision on what to use, and it is okay to ask the question so you understand that too. So let's talk a little bit about non-medication treatments for things that we would be using atypical antipsychotics for and things that we would be using mood stabilizers for. And so some of the same things we mentioned the first time, like exercise and increased activity and being out there and socially active and engaged are helpful, but also just having stability in your sleeping patterns and your eating patterns is useful. There are some evidence-based therapies that have been approved for various illnesses or diagnoses. And so I'm going to give you a little bit of information about ABA, almost like alphabet soup, but ABA, TCIT, PMT, that's interpersonal and social rhythm therapy, IPSRT, cognitive behavioral therapy, there's trauma-focused therapies, DBT, and family-focused therapy. Now, I know that one of the challenges that people have faced is where do we find someone who has training in parent-child interactive therapy or who has training in dialectical behavioral therapy. And I will say that there's an effort to try to train more providers in using evidence-based therapies and to try to figure out a way to have that be more available and accessible so people know and they don't have to search for those. So that effort is happening. I can't give you a date that it will be done, but it is happening. So ABA, Applied Behavioral Analysis, is the gold standard for autism treatment. It's a system that's based on behavior change. When it's effective, can bring about a lot of good positive change in behavior. You correct inappropriate behaviors through kind of a reward system. They use consequences, not so much now. Now they're using more rewards versus withholding rewards instead of consequences. TCIT, or Parent-Child Interactive Therapy, is behavior-based, designed to improve that relationship between the parent and child through their interaction. So you'll have a parent and a child in one room with a lot of play activities that they can do. There'll be a bug in the ear, a microphone device on the parent, and a therapist in another room. So the therapist is watching through the mirror the engagement between the child and the parent and telling the parent, okay, do this now, do that now, and then seeing the response of the child to the parent and trying to engage in a way where it shapes and changes their behavior outside of that therapy. And so there are lots of people, I think, that are doing TCIT now. Many people have been trained in doing it. There's also parent management training, which is kind of educating and coaching parents to change their child's problem behaviors using learning theory and behavior modification. The interpersonal and social rhythm therapy really is being used some for bipolar disorder, and it focuses on kind of consistent, stable sleeping and waking and meal times and consistent routine for better management. And so it, in addition to the medication management for bipolar disorder, has been helpful in the adult population. I'm not certain how much it's been used in the child population. CBT, cognitive behavior therapy, which is identifying those negative automatic thoughts and behaviors and replacing them with more positive ones. There is trauma-focused CBT, but there's also other trauma-focused therapies like child-parent psychotherapy, which is an evidence-based therapy for kids 5 and under, which works with the parent and the child together, and for children who experience trauma, which can be physical abuse, but it also can be a parent with mental illness, and so they've had some issues related to that relationship because of that, or a child has had significant medical issues, and that in itself might be traumatic. So, CPT requires a lot of training, and I know there's some people in St. Louis that do it, and then my team actually in Boone County does it as well. And then EMDR, and then therapy for complex trauma. Dialectical behavior therapy really focuses on that emotion regulation, and then family-focused initiatives. It's really important to include the family, and I think it's a no-brainer in kids, and probably do it more in the child and adolescent population, but you have to really include them in the discussion of the diagnosis and understanding the psychological aspects of what's going on in treatment, but also in supporting them through the process of working with their child. So now is the part where it would be great if people chat some things, because I do want this to be a little more interactive, and I would like for you to be able to ask any questions you have. But I want to talk a little bit about engaging your provider, right? And I mentioned earlier, in the past, the doctor said, so you did. And if you talk to some older people in society, they still believe that way. Well, the doctor told me to do it, so I'm going to do it. But it's not that way anymore. Now, the expectation is really that we work together, that there's dialogue and input, and that the person you work with may not be a doctor. It could be a nurse practitioner. It could be a physician assistant. It could be a resident in training, child health resident, a psychiatric resident. So it may not always be a physician. Part of that is that the access issues are a challenge for mental health for sure. There's not enough psychiatrists or child psychiatrists to take care of our patients. And so often it's the primary care provider or the extender people like nurse practitioners or physician assistants who are really helping manage children with emotional issues. So one of the things that is a challenge, I think, in the foster care population, and I don't know how to fix it, but it's not having the information when we have that initial assessment, and that's often because you don't have the information, right? So a kid comes into custody, it's done very quickly, they make an appointment, and we don't know about prior treatment. Whenever you are able to provide documentation or information about past hospitalizations or outpatient treatments or medications or any of that, that really is helpful because it helps to kind of shape the doctor or provider in what their next steps are. And so I know that there's, I'm sure, been discussion about how do we do that, how do we make it work. But, you know, I just want to put it out there that I think it really helps the dialogue, too. Well, hey, you know, I know this kid has been at SSM before, and this is what I know. Even if you don't have the document, having some of that information is helpful. And I talked about informed consent earlier. Remember, a key component of that is that the information about treatment has to be communicated in order for you to say it's okay. You know, there are some places, hospitals, who might have people do a blanket consent. So when you check people in, you're going to just sign the form that says it's okay to medicate or to treat. And so I would advocate, I mean, it's okay to sign that form, but at least to have some communication about what they're doing. To say, you know, I'm okay with treatment, but I really would love to have a conversation to help me understand better. And if you're not getting that information, whether it be an outpatient setting or inpatient setting, then it's okay for you to ask for it. If you don't understand what they're saying, then I would continue to ask questions until you do understand. So I want to stop for just a second and ask this question. What are the challenges you face when you are trying to get informed consent or information from a provider about a patient? What are the roadblocks you face? So while you're thinking of the answer, I'm going to answer a question that's come up on chat. So the question on chat is a 14-year-old child who weighs 175 pounds, takes 300 milligrams of Wellbutrin, what would be the side effects on that child, and does drinking peroxide make a child vomit? So Wellbutrin is listed kind of in one of my antidepressant medication classes, and so Wellbutrin comes in various formulations. There's immediate release Wellbutrin, there's sustained release Wellbutrin, Wellbutrin SR, and there's Wellbutrin XL, extended release. It is not FDA approved for any indication in the child and adolescent population, just an FYI. I use it. It doesn't mean you don't use it, but it's not FDA approved. So if a 14-year-old was on 300 milligrams of Wellbutrin, if it's the SR formulation or even the XL formulation, I wouldn't be so concerned. If it's the immediate release, it probably needs to be broken up. So the immediate release is usually taken at least twice a day, and maybe 150 twice a day. I'm assuming from this question this is 300 total, not 300 twice a day. So, yes, yeah, I've seen it, I've used it. I wouldn't see it as abnormal. It's not FDA approved. Possible side effects of Wellbutrin: decreased appetite with weight loss, problem sleeping at night. If they have an eating disorder, there's a concern that seizures are at an increased risk. If they have a seizure disorder, there's a concern that seizures could be an increased risk. And when you say peroxide, I don't know if you're talking about hydrogen peroxide. I don't know what that is. So if the person who gave that question wants to clarify, when you say drinking peroxide, do you mean like hydrogen peroxide that you use for cuts that doesn't like burn and sting like alcohol? That's what I'm thinking you mean, but I just want to make sure. So while that person is thinking about responding to that question, again, anybody want to kind of chat the biggest challenges you have when working with providers to try to get that informed consent information that you need? and I'll give you just a minute. And if no one has a challenge, I'll say this, because I think we have at least 42 on the line, then do you feel you're getting informed consent when you have a child in your caseload? Anybody for which that answer would be no, I'd like you to at least put it out there and let us know. And so either I'm getting feedback that either you all don't know how to chat or I'm scaring people and they don't want to answer. You just put mine down with 2 on it. That's the whole thing. Oh, okay. Okay. Oh, okay. So, I would be honest with you and tell you I don't know 100% about that hydrogen peroxide, but I'm assuming that maybe it was given in order to, from what is being said, in order to cause emesis in somebody who tried to overdose. I would say it is unsafe to do anything in the home with someone who's overdosed, and they need to go to the ER to make sure that they're okay. There are some things that they do using charcoal and things like that that I know more about than I know about hydrogen peroxide. So I'm sorry if I didn't answer that question totally. I just don't have the information. The next question is, what about Lexapro 20? What are the benefits versus side effects of it for teachers? So Lexapro, again, is in the antidepressant, anti-anxiety category that I talked about last time. And I'm trying to remember about FDA approval. I think it has FDA approval for GAD, but I have to look and make sure. And so it may be used off-label. It is used for depression. It is used for anxiety in teenagers. And the benefits would be the same benefits that you see for any of the SSRIs, which typically it reduces depression, and typically it reduces anxiety. Possible side effects might be headache, sleepiness. All the SSRIs can impair sexual functioning, so decrease desire. It also, all of the SSRIs are in the black box warning, so they might cause, the warning says, increased suicidal behavior. The studies of those are controversial. So if you didn't get to see my first webinar, I'd ask you to go back and look at it, because I do talk about the black box. I talk about the controversy. And it really depends on the level, I think, of their symptoms, their depression, anxiety, whether the benefits outweigh the risk. It is one of the least likely to cause side effects in that list. And if I have a teenager with anxiety and depression, I'm often going to go to Lexapro. So,
and just for reference, since you referenced that, the PowerPoint for the webinar number 1 that was posted on the calendar invitation, you had that.
Okay.
It was in
I think it was in July.
I'll have to double check that, and maybe we can put something in there to repost so it'll send again.
Okay. Other comment is, I feel as though I'm getting informed consent. I hope the kind of list that I gave you of all the things that should be talked about are helpful, that you can even kind of look at that and say, okay, are they telling me about alternatives to treatment, or just telling me about this one medicine? Are they telling me about what will happen if I don't treat? Those kind of things are all a part of informed consent. Next question, is there a requirement for children and youth placed into a psych hospital setting to get a history and physical and a psych eval within 24 hours of placement? So there is the requirement that within 24 hours of admission, a history and physical is done. I don't know the hours with which the psych eval has to be done, but there is a requirement for that as well. I know in the settings that I'm at the university, we get that psych eval on when they come up, right? And then there's a certain amount of hours that it has to be in the chart. But for sure, 24 hours on the HMT. There might be a little more leeway for the psych eval, but that has to be done too, if you're admitted to a psychiatric hospital. Next comment, I think we get consent most of the time, especially because we are the guardian. Next is, can you repeat the question? And the question was, what are the challenges that you're facing to getting informed consent? And then I didn't get any response, or at least I didn't see it at first. So then my next question was, do you feel like you're getting informed consent on your cases? Here's the next comment. I don't do a lot of case management and routine work with individual children, but that just seems sort of worrisome that a consent to treat would include prescribing a medication without discussing the risk. I mean, that's a part of it. You have to discuss the risk as a provider. If I'm really doing informed consent, and typically I will go through those elements, I'll talk about those elements. In my notes, I'll document. I discuss with the parent the risk of treatment versus not treatment. I discuss the alternatives to medication options and non-medication options. We discuss the FDA status of the medicine we're choosing and the potential side effects. And so that's a part of my note, and I've been training the fellows at the university, and I tell them that needs to be a part of their note too. Therefore, a part of their engagement with the provider and with the guardian. So yeah, there's a concern from some people that you would be prescribing without discussing risk or benefits. I feel like I do with my own caseload, but with my child psychiatrist always says I'm playing Dr. Mom and thinks I'm bringing my job into it. We go back and forth quite a bit. And I would tell you, number one, if it's one of my psychiatrists, tell me and I'll have a conversation with them. But number two, I'm the division chief for child psychiatry at the university in Columbia. But number two, you have no reason to feel bad about doing the best for your child. And in my opinion, you can't do the best for your child without information. And there's a difference between saying, well, you should do this or you should do that, and dictating to a doctor what they do, and asking for more information so you can understand the decisions that were made and disagree. If you disagree, you can choose as the guardian to say, I really don't want that. And I've had parents to say, yeah, I realize there's a lot of ADHD symptoms, and yes, they're not doing well in school, but I want to try other things before I try medication. And then I just document that what my opinion is, but as a team, we've decided, because it's not, I can send you home with a prescription all day long. And if you really don't want to do it, you're not going to give it to your kid. So why the battle? There's no point in a battle that as a physician, I'm never going to win. That's my opinion. So the next one is, how do you create interaction with an MD, nurse practitioner, TA who seems to be overwhelmed by the demands of a large practice? So, what has happened, I think, is that over time, they've asked us to see more and more patients, us as providers, in less time. So some places, depending on where you're working, may have 15 minutes for you to see a family, which is not enough, in my opinion. We still at the university give 30 minutes, and even that sometimes is not enough. You have to be with a provider that you feel comfortable with. And the challenge is there's not a lot, right? So the demand is large, the volume of potential people is low. But if you can't find somebody that you can really work with and feel comfortable with, I don't think it's good to work with that person under those constraints and just continue to go with the flow. If you feel like you can't communicate, then I think you should really think about trying to find somebody else. And, sometimes it ends up being a primary care provider and not a psychiatrist. And some of them have higher level of kind of comfort versus lower level of comfort with dealing with emotional issues. I'm working on, in several venues, I'm trying to increase the knowledge and the kind of comfort level of primary care providers across the state in treating mental health issues. And maybe with time that'll get better. But I just feel like it will be frustrating for you to continue to work with someone who you're having a negative interaction with.
Dr. Yolanda, is there a consultation process? So if you did have a primary care physician that you felt more comfortable with, is there a consultation referral source for that primary care physician?
So I would go directly to that primary care provider and say, do you feel comfortable treating John's ADHD? And some will, some won't. It may get to a point where they feel uncomfortable. It's not really a process. You just have to make sure they're okay with it. There are two things. I'll tell you about one. It's called ECHO, Child Psych ECHO. Child Psych Echo started May 12th. There's a hub team of experts, supposed experts. So I'm on the team, 2 other child psychiatrists, one in St. Louis, Ujjwal Ram-Fatir, one in Columbia, Garima Singh, a PsyD from Compass Health, a LCSW from Compass Health, a developmental pediatrician, a psychiatric pharmacist, and a health equity person. We are the experts, and we meet every second and fourth Friday with primary care providers across the state on video, just like this. And each week we spend 15 minutes doing a presentation, ADHD, depression, bipolar disorder, and then after that there's a case that one of them has submitted where they have questions about what do you do, how do you move forward, what are the treatment options. So we do a case every time, and we go through that. All the participants who are other PCPs give ideas about what should be done or what they do, and the experts do the same. That process started with ECHO for autism. And what is shown over time is that the primary care providers who participate start to feel much more comfortable with dealing with mental health issues and have less of a reliance on using child psychiatrists and psychiatrists. So our program goes for 20 weeks or 6 months. They get 20 weeks of didactics and 20 weeks of cases, and then we're going to do another 20. And that's 20 boxes on the screen. So one of the sites has like 4 people in a box, right? And so we can serve more than 20 providers. So that's why I said I hope that over time these primary care providers will start to feel much more comfortable. I will say many of them do not get much training in mental health during their residency. So they are kind of at odds with how to manage it. And I think instead of right now there's not a consultation other than that. I'm hoping to get some additional funding to do a phone consultation like Massachusetts has, where a pediatrician in live time can call up, get a child psychiatrist, they've got somebody in the office, hey, this is what's going on with Johnny, I've got him on this, what do you think? And the psychiatrist can say, have you thought about this, have you done that? So we're working to make that happen. It will start if it starts in St. Louis and then move to the central region. There are some things we're trying to do, but I think for now, you just need to go to that primary care provider and say, hey, I've got X amount of kids on my caseload. How comfortable do you feel with working with them? Is there a point at which your comfort level goes away? So yes, I'll do general ADHD, but I don't want to do psychosis. You know, that conversation I think is fine for having now. Here's a question. There are therapists out there who specialize in ADHD and teaching coping concentration skills. At age 7, my son was, diagnosed, and he went off all his medication his sophomore year after 5 years of therapy with a specialist. He then went on to graduate with honors. There is hope out there, but it takes more than medication. And if you'll remember, I spent a lot of my time talking about non-medication options, especially therapy, because you can't just use a pill to fix everything. You have to add therapy, and sometimes it's only therapy, depending on the severity of the symptoms. Any other thoughts? I think I may be getting close to my time, maybe. Okay. Any other thoughts or questions? Let me make sure of one thing, because I got carried away. Make sure I did all my slides. I think I mentioned that it's critical for that ongoing treatment that you have to have input. You can't just go into the doctor's office with the foster parent in lieu of talking to the teacher where the kid spends 8 hours of their time. Having some connection with the caseworkers, with you all who know some of the background history that maybe the foster parents do or don't know. This is a team, and in order for successful treatment for that child, that team has to really work together. And so the other thing is, you know, when you are, these are some kind of things to think about when you're trying to engage with your provider. Educate yourself on the treatment. So I'm not saying I know everything, but now you have these slides. You can look at the medications, and you can look at what I've given you, and it may be a first step. Be familiar with the side effects, especially the serious ones. You have to know about NMS if you've got a kid taking an antipsychotic. You have to know about Stevens-Johnson syndrome if they're taking carbamazepine. You don't have to know how to diagnose it, but you have to know to think about it when you get that call from that foster parent. Hey, you know, he's got this fever of 104, and I can't get it to go down, and it seems like he's not really with it. You need to know that so you can say, take him to the emergency room if that foster parent isn't aware of it. And then be aware of kind of the monitoring, and you've got that kind of table too that shows you what you need to monitor related to antipsychotics. It's really the fasting, lipids, and fasting glucose, and what you need to monitor related to the mood stabilizers. I think I went like I did this without you seeing the slide. So here you have some more links, linked to ACAP, and you've got NAMI has some resources, and psychotropic medication use parameters in children in foster care. There's a link to that too. Any other questions? If a child is on lithium, should they refrain from extreme exercise, especially in hot weather? So the issue is dehydration, and like either drinking way too much water and then diluting your lithium so the level is really low, or not drinking enough water and having a high lithium level, and extreme exercise may contribute. So you do have to be cautious about it. And if you're noticing that they're starting to have tremor or some issues, then you need to have them see their doctor, talk to the doctor, check their level. Anything else? So I do appreciate the feedback, the communication, the questions. I think it's only through being able to kind of put those out there that if they're on your mind, you can get them answered by me, and hopefully later you'll be able to ask those questions to your provider if you're having them and feel comfortable doing that. But I really appreciate everybody joining the webinar, and we have one more in November, and this will be available. So, all right, well, thank you very much.
Thank you.